Hello, everyone, and welcome to the Cytokine Signaling Forum Author Interview Podcast, where my name is Professor Peter Nash. I'm a rheumatologist at the Department of Medicine, University of Queensland in Australia, and today we are very lucky to be honoured to talk to Professor Leonard Calabrese from the RJ Fasenmyer Center for Clinical Immunology at the Cleveland Clinic Foundation. Len, thank you so much for giving up your time. We greatly appreciate it.
Peter, my pleasure, man.
Okay, so today we're talking about one of the press button issues. I work in the Asia Pacific hassles. One of the commonest questions we get from the Asia Pacific docs who are very, very focused on this Zoster issue is your lovely study you published in Arthritis Care and Therapy in July of 2019, which was a post hoc analysis of the live Zoster vaccine in patients with RA treated with tofacitinib with or without methotrexate or adalimumab with methotrexate, the oral strategy study. So thank you so much. Let's have a think, find the audience of what the oral strategy study was and why it's important.
Yeah, well, the issue of why it's important is, it's kind of a no-brainer. Zoster is a disease of formidable morbidity burden. We know that we in rheumatology, we make Zoster for a living. It's a complication of many of our therapies, but in particular appears to be a class effect of Janus kinase inhibitors. So the oral strategy study was a study of tofacitinib done in methotrexate inadequate responder patients who were then randomized to get either tofa as monotherapy, tofa plus methotrexate, or a comparator limb of adalimumab plus methotrexate. The twist to this study is that upon entry into the study, and while this wasn't mandated by the study, patients were given the option of receiving, at that time, you have to recognize this was live Zoster vaccine, about a month before initiating treatment. And so this was done, and the study was basically a post hoc analysis of that study to examine, the efficacy and safety of live Zoster vaccine in a real-world, application of these drugs. Most of what we know just come from examinations of safety databases. So that was the plan.
Excellent. Because such a difficult discussion, just at the time they're doing terribly and you want to put them on a biologic, it's not a good time to be stopping things for a live vaccine. What do you do in your own practice? Back to the study shortly. How do you kind of time all this vaccination stuff with people who are in trouble, need to go on to drugs?
Well, there's no easy way around this, but I will tell you, we are vigorous in this area, and I believe that anyone starting particularly a JAK inhibitor should be offered Zoster vaccination. We can talk about what vaccine we're using these days toward the end. And I would say regardless of age, my junior associate, Dr. Cassandra Calabrese, who has a rheumatology infectious disease clinic here, just was discussing a 35-year-old who's doing well on tofacitinib, who had horrendous Zoster, and now had stopped the drug, or Zoster treated, and she has recommended vaccination before going back on the drug. Anything that can be done to prevent these complications. So that's where our standard is.
Excellent. Can you give us an idea? What is the role of baseline varicella or Zoster serology? Should we be checking it, or is it a waste of time to just vaccinate everybody?
Well, in the era when we used to use live Zoster vaccine, Zostavac, could create a modestly reasonable question that you should check serologic status because this vaccine was not intended as primary vaccination. On the other hand, in the pivotal Zoster trial that used this of almost 40,000 patients, didn't assess baseline Zoster antibody status, and people did just fine. You know, people born before 1994 or so, virtually all of them are infected. So that was the old. The new is moving into recombinant vaccine, which is killed. And I see no reason to check this anymore.
Excellent. We'll talk about Shingrix a little bit later on, especially about this concern that all rheumos have that it's going to flare their rheumatoid when you give them this highly adjuvanted vaccine. But tell us a little bit about the objective of this particular analysis.
Well, now the objective was meager. As I said, since this was not mandated, the acceptance of the live Zoster vaccine was, only about 18% of patients, and this was not a random sample. So the N was very small, and it was really not powered for intergroup variations. And at the end of the day, there a relatively small number of Zoster events. 3 were in vaccinated patients and were in non-vaccinated patients. So even looking at hazard ratios between these groups, nothing was significant. The only thing that I found that was quite interesting in this was that there were a few events in both tofacitinib groups and 0 events in the adalimumab group. And we know that from comparative studies from other data that rate of Zoster is just higher with tofacitinib, made worse by steroids, made worse by methotrexate, than other targeted therapies such as anti-cytokine therapies. Overall, the therapy was very safe. There were no early episodes of Zoster, 0 to 42. That's a time period that if you get live Zoster vaccine and you develop those within the first month or two, worry that this is actually dissemination of the vaccine strain, and none of that happened. There were a few disseminated or multidermatomal episodes, but none that were dubbed as serious in the vaccinated groups. And so it was well tolerated. Was there a palpable protective effect? Perhaps. I think that alerts us to the problem, but we've now entered a new era, and I'm going to tell you that, we are not giving live Zoster vaccine to anybody anymore.
Okay, but unfortunately, outside the US and maybe Canada, we just can't get the killed vaccine, so we're stuck with this live vaccine for an extended period. This kind of information is very important to us.
To carry some over on my next trip.
That'd be great. So the other thing I'm trying to...
problems getting it stocked here as well.
Well, there you go. So the other thing I'm trying to tease out, because initially they tried to say that steroids clearly drives it, but the question of whether methotrexate does or does not, initially they suggested it did with... It didn't fit so well in the model with Barry. Your study... Comment on MTX driving the risk, because the 2 papers, Jeffrey Curtis and Kevin Winthrop, they blamed steroids, didn't blame the conventional synthetic DMARDs as well.
I think it's a difficult thing to tease out, because obviously if you're looking at the methotrexate population, it's often enriched for glucocorticoids as well. So any attempt to parse these out, even in the monotherapy, there's always a residual group. I look at glucocorticoids as the driver of Zoster. We know this from other diseases and other settings. Methotrexate monotherapy in the absence of steroids, I mean, I just have an informal concern about it, but it is not getting it off the hook because it's just, there's just no way to answer this definitively. We do know, as you're well aware, from other vaccines where humoral antibody appears to be particularly important, methotrexate is, has been surprisingly potent at inhibiting antibody responses, pneumococcus and influenza, and actually more than glucocorticoids. So it's not significant. Just don't have an easy answer.
Excellent.
But what I'd say, in conclusion, is that TOFA by itself, I think, loses some of its impact. With or without methotrexate/glucocorticoids, I think it's a different agent. And whether the newer drugs, I heard you talk about Berry and some of the attempts to look, I think it's going to take a longer time to sort this out. It looks like a class effect, but perhaps maybe not as robust. We don't know yet.
Okay, so we've been tending to stop for 3 weeks, try and miss a week of methotrexate or miss 2 weeks. How long should we wait between vaccination and starting the JAK to this zoster risk?
Well, our Committee for Immunization Practices, the ACIP, makes a kind of eminence-based recommendation of 4 weeks starting immunosuppression. And, sometimes we don't have that luxury. I'm very impressed with the data on methotrexate and influenza, that a 2-week hiatus has, very beneficial effects at boosting humoral response to this T-cell dependent vaccine. We just don't know in the Zoster group. The small study done by Kevin Winthrop that actually looked at giving a live Zoster vaccine and then giving tofacitinib 2 weeks afterwards. This does not get enough play that there was a single patient who had disseminated zoster in that study, and there were 2 things to be noted. One, this was disseminated Zostavax. This was not just reactivation of childhood zoster. And secondly, that patient had no immunization status to varicella at the beginning. So I say, I would shoot for the 4 weeks to be as safe as possible. 2 weeks, not quite as good, better than simultaneous administration.
Excellent. Do you want to just comment on some of those EULAR and ACR guidelines? Not to be the same. They almost seem to be.
First of all, they're all dated. ACR guidelines are as of 2015, and the Shingrix was not approved until 2017. EULAR guidelines are still somewhat behind the game as well. I think that, Peter, I can't speak for areas that don't have recombinant zoster vaccine, but just to say where this will be going in the next year or two, that we see no reason to be giving live zoster vaccine because A, it has only a 50% protection rate, B, it's relatively ineffective after the second decade, C, the protective immunity ex vivo wanes by 5 to 7 years. Zostavax, on the other hand, is 97% effective. It does not appear to wane, at least as the current follow-up, and it's equally effective regardless of age. So, on the pipe. And so you might say, well, I've got to give this Zostavax right now. What happens when Shingrix comes out? Current recommendations right now by the ACIP are that even if you've had Zostavax, you then should get the recombinant Shingrix at some point in time afterwards.
Excellent. So I know you didn't look at it in this particular paper, but from your experience, I know Mike Weinblatt showed 300 Shingrix vaccinated patients at EULAR this year and said 1.3% flares. I've heard this from other rheumatologists. They're concerned Shingrix will cause a flare of rheumatoid. Experience in that direction?
Well, I have waved significant flags in this area, and I've written an editorial about this in Helio Rheumatology. At this point in time, we know enough, and that was a very nice study from the Brigham, but it was retrospective, and it was looking for a blunt signal. It was a small number of flares. And to be quite honest with you, rheumatoid doesn't frighten me. I mean, if you have a flare of rheumatoid, I wouldn't want to have it happen, but we know how to deal with this. That I am very concerned about are in diseases that have clearly pathogenic autoantibodies, namely SLE and ANCA-associated vasculitis. And no one has done a study to date prospectively looking at the potential for Shingrix to influence the elaboration of key autoantibodies such as anti-DNA and ANCA. And so those studies need to be done. The company does, and we're waiting for some action in that area. They rumor that studies may be on the way.
Excellent. I think the field really needs something in that direction, because I recall the risk of Zoster back to patients in their 20s, and we worry about
absolutely. And it's heavily confounded by glucocorticoids, as you could imagine, but their rates in young lupus patients on heavy immunosuppression are reminiscent of the rates of Zoster that we saw in HIV in the antiretroviral era. They're devastatingly high. Strategies are clearly needed there, and so we need, before we can this kind of vaccine that's a potent adjuvant, we need clear safety.
Excellent. So just any take-home messages for the rheumatologists who are stuck with the live vaccine from your particular paper? Well,
I would say that this just continues to support, particularly before the class of drugs of Janus kinase inhibitors. I would encourage vaccination even below the age of 50, and I would wait 2 to 4 weeks, depending upon the time, to get things going. Over here, when we start these drugs, it takes us a long time to get it approved. So that's the time to have the discussion right up front. Down the line, I think that will be planted by recombinant vaccine, hopefully sooner rather than later.
Excellent. Thank you again for your time, Len. This has been the CSF July Author Podcast. If you'd like to know more about Professor Calabrese's paper and others uploaded to the CSF website this month, you've got detailed slide sets are available in the publication section. Go to cytokinesignaling.com. Please subscribe to this podcast on iTunes or other podcast media and give us some feedback and let us know what you think. Thank you so much for your time, Len.